Definition: heterogeneous group of diseases myocardium associated with mechanical or electrical dysfunction, which is usually not invariably exhibited inappropriate ventricular hypertrophy or dilation. That's pretty profound. And are due to a variety of etiologies that frequently are genetic. And that's going to be a big component of this. It either confined to the heart or part generalized systems. They can be progressive and cause death. I'm not so sure if it'll affect you, but it'll affect your practice as far as what you see. The WHO classifications are out there. They, again, it's like the NHIA scales and stuff, and who's moderate, who's mild, who's severe, things of that nature. Usually symptom-based. There's American Heart Association's nomenclature. Is it primary because if it's genetic? Is it mixed, meaning acquired? Was it disease-wise, infected, something? Secondary, multi-organ. Does it affect other than the heart and other things of that nature? This is a busy-ass slide. So, the hypertrophic cardiomyopathies, that's genetic, subaortic hypertrophic stenosis. Athlete dies on the court. These are things that are there. This mitochondrial myopathies might be something that you see, or conduction defects maybe. Ion channel disorders. Valvular disease is something that would be, this is going to be more specialized. I mean, I don't know how much they need to know on, Tammy, they need to know much on that? Yeah. I mean, this is really getting specialized stuff here. These people come in with just some funky ass rhythms. And all you need to know is, if that ain't right, I'm going to go get somebody. Trust me, because I've done that many times, and even being in cardiology, I was like, that ain't right, but we'll find out. Dilated cardiomyopathies can be mixed. Again, the ischemic causes. Is it other based pregnancy-induced cardiomyopathy? That's probably something you can see. Pregnant females, for whatever reason, come in, their EF's 20%. No known reason. Just happens. It's another thing you women get to look forward to. So, restrictive. It's just exactly what it is. These can be eosinophilic diseases and things of this nature, or things that just kind of restrict the myocardium from being able to relax entirely open. It affect the ability of the myocardium to work. Acquired, inflammatory type things, infection like myocarditis. Takotsubo, anybody ever heard of that? Oh, Takotsubo. Broken heart syndrome. I don't see you hear any men in there, Bonnie. Four cases of this I've seen. They present like an acute MI. ST elevations, troponin leaks, and it's usually due to a severe emotional event, losing a significant loved one or whatever. You go in, you do the angiogram, absolutely normal coronaries. EF can be reduced, but Takotsubo, it's a real thing, broken heart syndrome. It's interesting when you see it, because you're just like, man, I can't believe that load someone that much, I'd die for it. Peripartum, again, pregnant females. That's a big thing that they come in with as far as being acquired. Again, what's that one say? Tachycardia induced. Remember, treat the arrhythmia, or they will fail. Infants and insulin diabetics, that's more of a pediatric type thing. You probably get that somewhere else, but I don't know if you're going to really need to know too much about that one. Well, so If you didn't know the cardiac physiology, basically ventricles and diastole and systole, and diastole, obviously, the ventricular muscles are relaxing, right? Atrials are filling with blood, and systole, they're contracting. Obviously, in systole, it's ejecting, the diastole, it's getting blood from the atrials, right? Hypertrophic cardiomyopathy. Can be autosomal dominant. This is that subaortic type scenario. This is abnormally enlarging of the septal wall of the myocardium. Okay? This causes a significant gradient as it is going. So if you're just looking at the LV, okay, your mitral valve is here, your atrial valve is here. It does not matter where this is. Most time people diagram it as, you know, this enlarging here, and as this squeezes in, you know, shunning off blood that's going here. You can have it anywhere along this septum. If you get an increased velocity coming down the heart off the septum, that's hypertrophic cardiomyopathy. Okay? Increased velocities are not good. Okay? I mean, it says the septum covers it. Yes, that is somewhat things that are going on, but it's due to high velocity of the blood coming out of the heart, which would be more imperative about understanding that. And on an echocardiogram, you can see those velocities. Okay? When they do the 2D Doppler of it. It reduces the cardiac output that you can get out of your heart. So you're not getting all the blood that you need to in your ejection of what's going on. The left ventricle can become very stiff because it's trying to work too much, and because of the dynamics of the hypertrophy and the genetics of it. You know, normal myocardium lays in a linear fashion. When you do biopsies of these, you see just mixed crossing or doing things where muscles are constricting and going different directions and not functioning normal. Okay? Coronary blood flow. Did they talk to you about coronary blood flow? When does coronary blood flow go? Diastole, right? Well, it can't get into the ventricles when it's squeezing, right? So it's a diastolic functionality. If you ever get into balloon pump understanding, and when they put a balloon pump into somebody, especially after acute MIs, it really shows that dynamic of what's going on. I don't know if they got into that in coronary disease or not, but it's the diastolic flow, and that's why if you get not enough blood coming out and your velocities are super high, that retained flow that goes down into the coronaries is diminished, and why you get ischemic, and then why you fibrillate, okay, and why they die on the field. The heart's going so fast when they're running that when you're running, remember your heart's beating faster to meet your myocardial demand. And then you start cutting off flow and increasing velocities, and then flow's not going to get there. You can't meet myocardial demand, and the next thing you know, they're over here. Okay? Sudden death in athletes is why. Okay? Mainly during exercise, why? It's because of myocardial demand of oxygen. Right? It's an ischemic event. Symptoms look familiar, don't they? It's an ischemic event, right? Shortness of breath, chest pain, irregular heartbeats due to excitability of the myocardium causing PVCs, right? Enough PVCs in a row get you V-tach, right? Syncope, yeah. Can't get blood flow to your head, guess what happens? Night-night. So, if you're looking at it in clinical manifestations type things that are going on here, and you're listening to the patient, you are going to get what's called a systolic ejection murmur. Okay? Right? You're going to hear it. It's going to be loud. You Valsalva, it's going to kind of go down to slow it down. It's going to increase the sound of it. It's going to put pressure on there, and you're going to hear this. Right? Hand gripping and trying to do something. You don't do as much. You don't do anything. It's not going to be as effective as far as what they're straining on and doing and not breathing, so you're not moving as much blood or causing the things that are going on. The murmur kind of decreases. This is technical. Okay? Practicing it, you may not do it. The thing I would tell you is yes, you might need to know that for a test, what decreases, what doesn't decrease it, and all that kind of crap. Just know when you hear that murmur, guess what you're going to be doing? Hitting an echocardiogram. And then a young child, you're going to get an EKG. Right? You're going to look for that hypertrophy. People tell you that LVH on an EKG doesn't mean anything, they're full of shit. It's important to understand that. PMI, anybody ever felt PMI? Put your hand on your chest, feeling the apical pulse. You know, is it displaced down, is it moved? Good luck.
As far as your boards go, hypertrophic cardiomyopathy, that is the murmur that will increase with Valsalva there, but then also they say like for squatting on your physical examination, that's how you will, that will present like on the boards. And that is the only murmur that will be louder. When you
Do they tell them squatting? To do it squatting?
Squatting or Valsalva, either one.
So Valsalva, do you know how to tell someone Valsalva? Most patients don't understand Valsalva. Take a shit.
Yeah.
They understand that. Radiographic cuff. Okay, so gold standard, no question, echo. I mean, if you're going to do anything, echo is always gold standard in heart, right? That's your second stethoscope. All right, hands down, I ordered more of those in my lifetime than I could even count. Septal volumes, you know, anything greater than 1.3 millimeters, one, you know, that thickness that you can see, they can measure it, they can do it. The LVH on EKG can be, not always there. You know, kids, they can be a little hard to see. You'll figure out in pediatrics, those little bastards are hard to diagnose. Genetic testing, obviously, there is some things in looking at chromosomal deficiencies. Family history is a huge cue when you're doing family results. Any sudden death in the family. Anybody ever had sudden death that you know of? So those are things. Again, they're talking about the normal heart muscles like we just talked about. It's disarray, it's functionality that becomes a problem because of that disarray. Does that make sense?
So you said there's a genetic test?
Yeah, I mean, they go back over the autosomal, all these autosomal dominant, MYH7, M1PV3C, they can try and test for that. I mean, those aren't things that you're going to do. You're going to get to a specialist, or if you're in the specialist's office, you're like, hey man, what was that test mean? And you do that. But, so, I mean, it is something that you'll look for as far as, well, fibril disarray. Biopsy is a good way of doing it as well. It's invasive as hell. It's interesting with this and therapies that they do, and myomectomy, it's not always effective. Cutting out the septum, you think it would be, but just lopping off the septum doesn't always reduce the vascular flows and increase velocities and things. Pacing, moving the septum away from the aorta when it's ejecting. The rate of this prognosis is, is diminished nowadays just due to more of its understanding and quick diagnoses of it. Obviously, if you have somebody, you're damn sure going to tell them no sporting activities, right? Anything increasing heart rate, anything that does. Hypertrophic cardiomyopathies, typically our treatment for it is using negative inotropes, okay? Something that slows the heart rate down, something that stops the ventricle from squeezing aggressively. Beta blockers are on negative inotropes, okay? Calcium channel blockers, some are and some aren't. Cardizem, verapamil are, Norvasc would not be a good one, right? Norvasc speeds up the heart rate. It's kind of like nifedipine, right? You got into valvular dysfunctions? Aortic insufficiency, like for instance with nifedipine, that's the drug of choice. I don't know if cardiologists are doing it now. Most times you see them put on a FARB or an ACE to reduce pressures from doing it. But to decrease the diastolic downtime, to lessen the amount of time that the ventricle is allowing the blood to come in to go out, if you increase diastolic downtime, you have more prolonged aortic regurgitation. If you reduce diastolic downtime, you don't have as much, and you're moving blood out without it getting stressed. Nifedipine is a drug of choice that I was taught as what it is. A lot of people do ACE and ARB inhibitors, but anyway, that's for your valvular disease. Hopefully someone can teach you better than me than that. But negative inotropes, right? You're trying to stop the heart from being aggressive in a hypertrophy, if that makes sense. You don't want the heart to be aggressive in pushing blood out. You try to relax it a little bit better, and so that it gets the most amount of blood flow out of the heart and slowing the heart rate down to be non-ischemic, right? Again, ICDs, obviously, people fibrillate. That's what they die from this, right? So, shocking them out of it, better than putting them on amnio or cardiac surgery. Again, myomectomy, that's not always as good. If it's severe enough, heart transplantation does come into effect here. I haven't seen that in quite some time for a hypertrophy. No competitive sports, right? You find one in the family, guess what? Siblings and everybody else going to get seen and treated, right? It's imperative that they stay healthy. Good luck. You know, the fatter you become, the more you got to perfuse, the harder the heart works, the higher the perfusion pressures are. You know, you got to stay healthy. Immunizations, making sure you're not at risk of infections and things of that nature. Medical bracelet, in case you do pass out, people understand what the hell happened, right? Just like diabetics have bracelets or any of these others, you know, it's always a good thing to say, hey, I got a hypertrophic cardiomyopathy, this could be it. They do need to be followed by cardiology. They need to have that specialist always watching them and seeing what's going on and this and that. So, you know, if you're in a primary practice, you're always going to refer the people on. Evidence based. That's all we do, right? Y'all read journals? Stay up on clinical trials?
Yeah.
I thought it was a bunch of bullshit when I was in school, especially with all the crap that you have to do and staying up late at night just trying to do your text. But when you get out, you will change from being a didactic practitioner, learning and trying to get this knowledge, to finally doing what we call practice medicine, right? And that's what it is, it's practice. You take what you learn, you apply it, you think of the physiology, you think of what's going on and why you do it. You read studies of what studied this effect, of what medications it did it, like I was telling you about maybe the whole trials. They show you what is good and what is bad. That got me away from what we thought was malpractice when I was in school, and what we do now is totally different. Medicine keeps changing and evolving. And it's just amazing how so many damn specialties are out there now. I mean, as a family practice type thing, you're almost encompassed to make sure you know a little of a lot versus someone who's specialized and knows a lot about a little. So it's just make sure you stay up with kind of journals and reading and here and there. I mean, they are good. Dilated cardiomyopathies. These are the ones, obviously, that the ventricle gets huge, right? Can be ischemic, can be due to whatever it is, but it's the dysfunction of the heart to contract or push blood out. Valvular disease can cause this, multiple things. The EF is usually reduced. Again, you know, we just went over the heart failure type things, and it's what you're usually going to be doing. Heart chambers are dilated to compensate, right? Can't move blood, and it gets worse. The heart will grow, okay? Especially in mitral regurgitation, okay? So when we constantly get an echo on like a valvular disease patient, you're always looking at the dimensions of the ventricle, okay? Someone who has an EF of 20% has severe mitral regurgitation has a functional capacity of a normal EF to a person of 10, right? Because basically, if you have a 20% ejection fraction, 10% of that's going back up into the atrium, the other 10 is going out of the heart, okay? It's imperative to know this because if you dilate in a mitral regurgitation and the EF is reduced significantly, and you go put a mechanical valve in that patient to replace the mitral valve, you know what happens when they turn the heart back on? Takes one beat, the patient dies. It is a significant mortality rate. So when you've got somebody with mitral regurgitation that they should, I don't know if they'll go over it, but because of dilated cardiomyopathy, if the left ventricular is getting bigger than 55 or starts getting up to 55, you know you're going to surgery. You're getting mitral valve replacement. Because if that EF starts reducing or that ventricle starts dilating, the chance of morbidity goes up significantly. And usually they won't replace the valve in someone like that. They might try to just repair it, and they're fine with maybe moderate regurgitation or mild, but at least that ventricle has some type of compensation to push blood through the heart. But hopefully you get to a point where that's not the case. Heart chambers, they all dilate. Every one of them can. The left ventricle and the right atrium are more significant than the right side. Other than the right side of core pulmonale can be somewhat problematic. It's not always life-threatening as what the left side is. Okay. Obviously, the dilation can get progressively worse. The dynamics of trying to treat this, especially, you know, whether it's ischemic or not, you're trying to keep that neurohormonal balance in the body at check so that they have the best possible capabilities of not getting any worse. This could be due to infectious etiologies. It could be just due to anything. You know, some of the worst ones I've seen are probably the postpartum cardiomyopathies in women. Sometimes they don't come back. Genetic protein dysfunctions and muscle contractions and stuff, again, that's kind of more of a specialty type things, but there is a genetic component to it. Infectious myocarditis, inflammatory type responses that could do it. Again, pregnancy can do it, and idiopathic, who the hell knows? You know, it just happens. You know, sometimes it used to be back in the day when I was, before all the therapy was there, that somebody who came in with an acute case of a dilated cardiomyopathy that got put in the ICU, they tended always to kind of get better and go back to normal. It's those patients that came in with the acute case that had mild symptoms that you just didn't need hospitalization, always did worse. But now with therapies and stuff, it's not so much the case. The pregnancy one is the biggest one. You have a pregnant patient who's short of breath, there's all kinds of dynamic damn things that can go along with the female, but you know, the heart's one of the things that you gotta watch. Signs and symptoms, just kind of like what we've seen before, right? Fatigue, shortness of breath, you're not getting your perfusion demands, you're not getting your oxygen demands to your body. That's what the heart's there for, right? So swelling, again, right-sided failure, edema, ascites, again, your belly's getting big, you're getting things going Tachycardia, remember the heart's trying, or the body's making the heart try to compensate to get blood flow through. If your output's diminished, you increase the volume, or increase the rate, you increase the volume, you get the output. It's not what we want, but that's what you're saying. Tachypnea, acute heart failure, the lungs half full, you only have half your lungs to breathe out of. You know, they're going to get very quick of breath. Try to get the oxygen in and out. Hypertension, I mean, it's not always a sign of a cardiomyopathy, but hypertensive cardiomyopathies can be there. You see in cyanosis, they're in Chicago. That's not good, right? They got their lungs totally full, they can't get blood, you know, oxygenated. Okay? That's a bad sign. JVD again, you can see it, remember? 5, 10, 15, you're looking at it. Hepatojugular reflex. It's fun to do, you can see it. Pulmonary edema, again, crackles, wheezes, bronchi, rails, whatever you want to call it. S3 gallop. Anybody ever heard an S3 gallop? It's impressive when you hear it. It's one of those things where you come back and you're right. Hepatomegalia, again, liver congestion, looking at liver enzymes, you're doing blood work. Okay? You know, they don't typically get jaundice because it's not really liver disease, right? Their bilirubin's not going through the roof, it's still functioning normally through the bile ducts. But it's AST, ALT, all that kind of stuff that you know, cirrhosis of the liver and stuff. Might be a little bit harder in your alcoholics. This is another one that they haven't mentioned on here is an alcoholic cardiomyopathy. People drink themselves badly. This is another case that you can see. Again, same thing as far as your cardiomyopathy. You should go B&P. Is it 2? Is it 5,000? What is it? You know, is it acute? Not EKG. Really non-specific findings on this. Sometimes you don't get the LVH because, you know, the muscle mass hasn't increased, just the volume inside the ventricle has. So you might get non-specific ST wave changes, you know, flattening of T waves, maybe downgoing T waves somewhat. It's just not specific overall. Maybe an axis change. You know, if y'all understand axis, right? You know why it is that, you know, the heart kind of sits in the body this way, right? So it's going diagonally across, but if it dilates and moves, it might swing more leftwardly than it should. That would be a right axis deviation. It would be hard to kind of see, but axis would be a change that you would see on an EKG. Chest x-ray, kind of easy, right? Heart, it's about what? Half to a third, right? You do it. If it's the whole entire chest, you know that ain't right either. And again, gold standard echo directly measures the chamber sizes for you, right? Well, looky there. We're treated like heart failure. Y'all pretty pronounced on heart failure now, right? Good luck. So all I can say, good luck. I mean, especially with diabetic patients. You sure you're eating lean meals, fish, and vegetables all the time, Doc? Just saying, your hemoglobin A1C is only 10. Referral to cardiology, obviously. Primary restrictive. These are the ones that are pain in the asses, right? These are the ones that are very, very difficult to treat. They're rare. You don't see them as much, and the presentation can be a little awkward and confusing. Okay? These are diseases that affect the myocardium itself to keep it from relaxing entirely after constricting is what? They just can't move. They're stiff. They can't do much. And that's a problem because we don't have great treatment for this, right? And I mean, it could be genetic in its nature. It could be, you know, cancer patients, you know, breast cancer patients. What happens to them? Radiate them. There's a reason radiation ain't the greatest, right? The reason why Chernobyl we don't get to go into, right? It's not good for you. But if they get enough radiation, especially from a cancer exposure and things of that nature, scarring will happen, disease will happen to the myocardium. Hell, it could happen just to the covering of the heart. Constrict it off. It's a little bit easier to treat, you just go in there and remove it. By the way, does anybody know the percentage that we know in medicine today that we can actually cure? It's like 1 to 2%. You know what the cure that we have is? Cut it out of the damn body. So just remember, everything we do, we manage. We never cure, right? There's still diabetes, there's still cancer, there's still all kinds of crap. Just managing. That's why you ought to read your journals. It tells you how to manage them. Anyway, infiltrative disease, this amyloidosis, it's kind of interesting. Getting that echocardiogram, man, the heart just brightly shines. Like a calcified vessel on x-rays or something of that. You just get an echo on there and it is. And that's just inappropriate protein disposition into the myocardium. And it stiffens the ventricles and keeps it from really doing it. Sarcoidosis is probably some of the others that you'll probably see. Sarcoidosis is a bad rheumatological disease. Have you had rheumatology yet? Yeah. Hopefully you stay awake in those lectures. It's just the body just attacking itself. It's hard to treat yourself when you attack yourself. So it's sarcoid, kidney, lungs, heart, liver, you name it. It's difficult to do that. You're basically going to be sending that to the cardiologist and the rheumatologist. Genetic diseases where metabolites can be deposited, could be in there. Very hard to kind of diagnose and see. You just know it is. Anybody ever heard of hemochromatosis? What is hemochromatosis? So you have excessive iron in blood work, right? But it's excessive iron in a bodily tissue, right? In the parenchyma tissue, either the lungs, the heart, or not. There's another condition that a lot of people don't understand. It's called hemocydiosis. Hemocydiosis is a precursor to hemochromatosis. Cydiosis is the elevated iron in blood and things. And for that treatment, a lot of people still call it hemochromatosis. You know what the treatment that you do is? Phlebotomy, right? Kind of the old, just cut the artery and drain them, right? And leech on them. But it's hemocydiosis before it becomes chromatosis. Chromatosis is a disease of the tissue. Ventricles fail to relax. They can't dilate, they can't get the blood, they reduce decrease cardiac output. Okay? They stay the same size, can't feel properly, you know. It's just hard to get the functionality of that muscle. Decreased feeling, increased volume loads, you know, diastolic heart failure, you know, that it's hard to say the LV-EDP might not be elevated on this is what you'd see, but again, in diastole, because it can't get the blood, it's obviously a diastolic dysfunction. Okay? And you'll see diastolic dysfunction on certain reports or something, especially coming from cardiology, but that's what it is. Diastolic dysfunction is just, I hate seeing it just because it's hard as hell to treat. It's just what it is. Same things as far as heart failure, just because of dysfunction, because of pressure buildups that go from the LV to the lungs and everything else. You get the same type of response as far as shortness of breath, not meeting myocardial demands and oxygen demands of your muscles. That comes out in a hormonal response and go, I can't catch my breath. You're weak, right? Your muscles aren't getting the nutrition they need, the oxygen they need. You're fatiguing because you obviously don't have the capability of getting exercise-induced type things. This is problematic because you get edema, and so when you're trying to treat this, yeah, I'm fatigued, doc. You got to get out there and walk. You have to get your body in condition to understand the physiology of it, right? They don't want to do it. So it's just a constant battle and fight and trying to treat and do I don't have that one pill that's just gonna fix you. So it continues to be a problem. But again, ascites, because of pressure buildups and everything is going back into the wrong line. Chest x-ray is gonna be normal, right? Maybe some pulmonary congestion, maybe not. Heart size not gonna change. It's just that the muscle can't function, right? Low voltage is a significant thing. If you see low voltage throughout an EKG, your number one suspicion is cardiac tamponade, right? If you got fluid augmenting it, you know, that's the bigger thing that you see, but that's a life-threatening condition. You got to stick the needle in there and you pull all that stuff out and hoorah. Maybe your sphincter tongue gets a little tighter. But low voltage can be seen with that just due to the electrical dysfunction that you see. Echocardiogram, obviously you're going to see probably ventricular thickness, but you're not going to see too much. You know, maybe that LV/EDP is up and stuff, you don't know. It can look like pericarditis at times, especially on EKG. You know, you get angiograms, cardiac MRIs, biopsies of it, just to kind of look. You sometimes look at it and kind of freak out a little bit, but these are the things that you're going to be looking for just to kind of rule out causes of it. It's not life-threatening, but.
What do you mean by low voltage? Is that there's some
So, you know, when you look at an EKG, they have standards. So, you know, if you get an EKG and someone doesn't know what they're doing, right, you should have normal type QRS type functionality. And down here they have that box, right, that shows you what it should be. So if your box is here and it's in a standard form now, it could be that, you know, this box is up here, and so you're going to get these small little complexes. Versely, if it's down here, you know, you're going to get these huge things like this. You're like, what the hell's going on here? So you always check to see, do they have it in the correct millimeter dosage? But if it's there, if it's normal, and you're just going to get these lower amplitudes, you're not going to get these high amplitudes. Okay?
EDB, QRS.
Yeah.
What's the box? Is it this thing?
We've never been told about it,
We
or
haven't.
at least I don't know what it is.
Does anybody have their EKG?
We haven't.
Or is there like something, a trace that we don't know?
Those are like some of
Okay,
the
okay, this box is right here. See this line that goes up and shows you, and it's going up the two boxes, it's a standard electrical amplitude that it's doing on the EKG. So it's a standard amplitude that's showing the electrical impulses that are coming, that's going to size your EKG. So if it's lower and stuff, it can augment the response of it. If it's higher, it might lower the response of how much electricity that you're doing. So it's a scale that should tell you what's normal and what's not.
And it should be 2 large boxes.
2 large boxes.
So then the low voltage will be throughout the entire
The
EKG?
entire EKG.
Okay. And that would make you think of cardiac tamponade.
One of the ones that you will see on the sidebar here, just for your knowledge. So you get an EKG. You got Dolly Parton that comes in, right? She's got big old breasts. What you'll see on that is that she might come up with anterior MI. And the reason being is that the R wave's not progressive. So in your pericardial leads, V1 through V6, right, your R wave should progressively get bigger, right? But if you have significant amount of breast tissue, it's going to reduce that augmentation of that flexion of the electricity coming there. You might not get an R wave progression. So it's not acute MI, it's just poor R wave progression. Females usually have it because of breast tissue. Fat man might have it just because he's got breast tissue too. Any more questions? I guess this comes to no surprise, poor prognosis the way I've been talking about it, because there's not much that you can do with this. These are usually people that do have transplants. And nowadays, specifically, you have drugs, when you transplant something, nothing's always normal, right? They have the anti-rejection medications, and these people have quadruple lists of medications that they have to be on. And some of the medications now actually stop having some of that progressive disease maybe attack the transplanted part. So there's been some progressions in that, but again, we transplanted the heart, same stuff can still happen, right? Nothing really changed in that body except for a new heart, okay? These are hard cases. I'm just glad they're rare, but they are very hard. No odds? Okay.
I don't think that they realize that that's what you were talking about. Say that so that they can recognize that that's how you
Taco
spell.
Subo? Taco Subo, broken heart disease.
No.
Taco Subo. So, anybody see anything wrong with that? You know what we call those? Anybody ever heard the term for those? Tombstones. Alright? In your coronary disease, did they go over the significance? Did they teach you the significance of ischemia versus infarction?
Yes.
Infarction specific, right?
Yes.
Ischemia is not.
Yes.
Okay? So this looks like a very large anterior MI. That's an LAD lesion, right? Also looks like the circumflex is the low leads, low lateral leads, V5, V6, circumflex. The 2-3 and AVF, right coronary, right? So it's all over the place, but it looks like a large anterior. If this really was a large anterior, what would you expect to see? See a reciprocal change in 2, 3, and AVF? But this is all the way across. This could be peritonitis, right? Myocarditis. Pan,
Pericarditis.
it could be, when it's pan elevation like that, affects the whole heart. You don't know. Either way, this guy's going to cath lab, right? So, looks like it. Actually get troponin leak from it. You're getting a reduced EF from it. And I just went somewhere else. Is that it?
Yeah.
Shit. All right, well, I guess I cheated y'all again. If I talk to Suba, that's what it is, but again, those are some of the things they got. Any questions or concerns, or maybe there are other questions in cardiology that you might want to know?
So for that, you said that this will be the EKG for placebo, but there's not any like blockage of any of the arteries when you do an
When
angiogram,
you do
but
an
it still
angiogram.
will show up as like an MI.
Yes.
Oh, okay.
As well as your troponins will be gone.
Your troponins will be elevated. They'll actually be leaking into broken, it's like all broken heart. Huh? You're treated just like any other type of coronary type phenomenon. So you'll actually put on, pilots, and you'll treat any ischemic type causes to the heart if it's dysfunction, heart failure, and things of that nature. And we'll be on aspirin and things of that nature and follow them. I'm not sure how they progress, but this treat just the same as like coronary. Anything else? I guess y'all can go out and enjoy this wonderful day.
Some of you guys had some questions over the dysrhythmia lecture from Dr. McNeil about the test. So, know how, and I'm getting ready to discuss a handout that gives you rules of Dr. Bennett's treatment EKG. I don't have it completely done, so it's not going to do by the end of this week. On your dysrhythmias, know the definitions. So if we were to describe that, know what it is. So absent P waves with an irregular rhythm. So you're going to know that throughout all of those that Dr. McNeil went over. The causes, and he went over a couple of treatment scenarios yesterday that you guys have never had before. You need to know those. So like your H's and T's for your causes. Don't dismiss that whole lecture. It's stuff that you're going to need to know. You're going to need to know it more and very thoroughly when you go to emergency medicine in November, when you also do ACLS. That's when we'll start throwing in the medications and dosages and the protocols to treat those dysphagias. Okay? You don't need to know all the protocols now. Is that more clear?
What were you saying last night? Doing EKG? Yeah. All the new ones? Like, tell them for like maybe like play with the like, I don't know, was it Are you going to Crampton or? Yeah. Okay. I have to run too. Yeah. I was like, we could hear you.